Hi everyone. My name's Lachlan Coyne, and I'd like to thank you all for joining us today for this UMCCR seminar. And before we begin, I'd like to first acknowledge the Wurundjeri people of the Kulin Nations, who are the traditional custodians of the land on which we are based. And I'd like to pay respect to their elders, past, present, and emerging. And I'd also just like to note that today, June the 3rd, is actually Mabo Day, and it's the day commemorates the efforts of Eddie Mabo, who in 1992 led a campaign to overturn the legal concept of terra nullius in Australia. Now today, it's a great pleasure for me to introduce Dr. Amy McCart-Reid, and I'm very happy that she's agreed to give a presentation today on implementing whole genome sequencing in the breast cancer clinic. Dr. Reid is based at the University of Queensland Centre for Clinical Research and has a long-standing interest in the molecular pathology and genomic basis of cancer, and most recently in breast cancer. And Amy works extensively with archival samples and has made extensive contributions in the area of understanding special types of breast cancer, including lobular and metaplastic. Dr. Reid is passionate about clinical research and biobanking. And in addition to the breast cancer research portfolio, she's a founding member of the Brisbane Breast Bank Steering Committee. So I'll hand it over to you, Amy, and look forward to your presentation.
Thank you for the introduction and the opportunity to speak today. I'm going to tell you a little bit about the work that we're doing in breast cancer genomics. But before we get to that, I'd like to just remind you that in the most overstated comment regarding breast cancer, that it's a very heterogeneous tumour type. And I'm coming from a molecular pathology background. I particularly love this image that gives you a great understanding of how diverse the different subtypes of breast cancer actually are. So the most common cancer types are here at the top, the ductal or an invasive carcinoma of no special type. The lobular breast cancer is the second most common type of breast cancer. And you can see here at the bottom this vast array of some of the more common special types. We know that there are at least 20 different histological subtypes. And we don't just use the histological subtypes to categorize breast cancers. 20 years ago now, microarray technology informed the categorization of breast cancers into about 6 types, depending on which algorithm you'd like to use. And these are called the PAM50 subtypes. About almost 10 years ago, some work out of the Metabrick Consortium demonstrated that if you integrate genomic variations with expression and mutations, you can get these integrative clusters, of which there are 10, and each have differing prognostic outcomes, as you can see by this breast cancer specific survival measurement of a Kaplan-Meier curve here. And realistically, treatment and categorization of breast cancer in the clinic at the moment comes down to expression of predictive biomarkers. And in particular, we use estrogen receptor, progesterone receptor, and also the HER2 receptor as well. And you can see here, we typically use immunohistochemistry or in situ hybridization for HER2. And expression of these markers makes you a candidate for treatment for hormone therapy or for anti-HER2 therapies like Herceptin. So as the kind of genomics explosion has occurred, there's been release of a number of companion diagnostics used in breast cancer diagnosis. And I've just laid out 4 here that are quite different. Basically panels ranging from 8 to 70 transcripts are measured by these panels. They can be array-based, qPCR, or using the nanostring encounter technology. Vast array of pricing strategies, none of which are covered in Australia at the moment. And a number of trials have supported the use of these companion diagnostics in the clinic. They mostly focus on estrogen receptor positive disease, and they mostly give a definitive outcome regarding whether or not someone needs chemotherapy, which is very useful. However, we can get a good idea about who really needs chemotherapy or not from standard immunohistochemical and clinicopathological guidelines at the moment anyway. So the actual utility of all of these tests really in breast cancer remains to be seen. There's also the Foundation 1 companion diagnostic, which is targeted for, I think now 18 FDA-approved therapies, has 2 immunotherapy markers and categorizes substitutions, insertions, deletions, and a copy number analysis in a panel of 324 genes. We've recently increased the breast cancer specific alterations on this panel from 1 being HER2 amplification to also include PIK3CA mutations. So again, in terms of value for a breast cancer patient, this test it's unclear. So what is the need for genomics in breast cancer then? Basically, since the definition of the breast cancer genomic landscape with the publication of the landmark 560 whole genomes paper in 2016, and also on the back of some pioneering work by the Cancer Genome Atlas in 2012, wherein they profiled 825 samples for RNA exomes, copy number analysis, methylation, reverse phase protein assays, and also microRNA sequencing. We have an immense amount of data, and realistically, we've yet to move this forward to improve the companion diagnostic. So if we take the TCGA data, and I've just plotted out the genes at the bottom of 147 breast cancer driver genes, and I've pulled this list together from the 93 driver genes of the 560 whole genomes paper, but also added in a few other genes that have come out of several different studies. And if you look at the percentage mutation over here on the y-axis, you can see that in terms of the number of genes that are mutated at a high frequency, it's actually very low. And we fall back again to PIK3CA, P53, and MYC. So what have we learnt from this kind of analysis? Basically, we're in the position where no 2 breast cancer genomes are the same. And on the back of the extreme heterogeneity that we see in morphology, we really are looking at a lot of unique tumours. So how do we apply this to precision medicine? Essentially, a tier 1 alteration is when the drug and alteration match is considered to be associated with a proven outcome improvement in clinical trials, so that the access to the treatment should be considered standard of care. So at the moment for breast cancer, we have the HER2 amplification. We are moving towards germline BRCA1 and 2 alterations and PARP inhibition, although we're just waiting for final reporting on some trials there. And we also have now, after the SOLAR-1 trial, the link between a PIK3CA mutation and alpelisib, which has been FDA approved in the metastatic breast cancer setting. So what about genomic signatures? The somatic mutational signatures are really a genomic scar, and they provide a history of the genetic insult sustained by the DNA. And we can use this information to infer a functional defect and also to identify actionable targets. Now, the COSMIC database keeps a repository of all of the signatures that are relevant in cancer, and last year updated the version 3 of these mutational signatures, which was an incredibly overwhelming amount of data released at once. And we went from the previous iteration of having in the 20s number of signatures to having almost 100 different signatures relevant in cancer genomes. So as much as the data is overwhelming, so is this picture, so my apologies, but I've blacked out some of the other cancer names here, so we can just focus on breast, which is the 4th one in. And you can see here that the size of the circles gives you an idea of the proportion of tumours that have that signature. And the colour reflects essentially a mutation burden as a result of that signature. And this was beautiful work from Alexandrov and colleagues that really helped to sift through all of this vast information of signatures generated through the pan-cancer whole genome analysis. And I've just identified in pink here the signatures that are relevant in a single base substitution in breast cancer. Not a huge number. So we have APOBEC activity here and also deamination, but also APOBEC down here. So not a huge number of known etiologies, a few down here with unknown etiologies across many cancer types. So there's a lot of interesting work still to be undertaken to uncover the background of these stories. But if we also have a look here at a double base substitution and insertion deletion, it's clear here that the indels are really important in breast cancer. Again, the fourth column here, and you can see that we have double strand break and we have mismatch repair as well, and a couple more of unknown etiology. So what does that mean for the clinic? Well, we know that BRCA1 and 2 mediate HR or homologous recombination DNA damage repair. And it's clear that a whole genome sequence derived signature can predict the absence of a functional complex. We also know that tumours that are defective for HR will likely be responsive to PARP inhibition and also to platinum-based chemotherapies. And there are a number of trials ongoing in advanced breast cancer. And some recent work from my colleague, Pete Simpson and others, has shown that actually whole genome sequencing computation of the signature is more informative to predict a defective BRCA1 and 2 complex than a germline variation in BRCA1 and 2. So it is increasingly clear that the signatures are going to be very important in breast cancer precision genomics. Now, another kind of signature is the tumour mutation burden broadly, as I'm sure everyone's aware that the mutations can result in translation of neoantigens, that we can get a good idea of tumour neoantigenic load based on a tumour mutation burden. And specifically in breast cancer, it's been reported that there's a high tumour mutation burden in up to 20% of metastatic breast cancers. And this is a significant increase on that which we see in the primary breast cancers. And again, as I'm sure you're all aware, there's a lot of trials ongoing for different immunotargets. What we need though, and are really waiting for, is that something that's a little bit more palatable in the clinic, something straightforward from a diagnostic point of view. So we need clear definitions for immunohistochemistry requirements, and we still don't have them even for PD-L1 and PD-1, which have been sort of the most around for the longest in the clinic. And we also need some better standardized cutoffs for tumour mutation burden and what that is actually predictive of in terms of therapy. We also want to keep in mind the importance of pharmacogenomics in breast cancer. So this is a really emerging field, and we can use single nucleotide polymorphisms that are identified in whole genome sequencing or targeted sequencing to get an idea about drug response, but also critically to get an idea about adverse effects that are induced by the drugs. In particular, I'll draw your attention to here in the case of adverse effects, the fluoropyrimidines, for example, capecitabine. It's often a second-line therapy in breast cancer, can result in severe toxicity. And there's now a very reliable SNP prediction here for this toxicity. And we find that even private path labs are now offering tests to determine the status at SNP to inform second-line therapies. So, you know, the key thing to note here as well is not all are in coding regions. And this is really a burgeoning field. So I imagine we're going to need to be pretty flexible to be able to include a lot of these new targets as we move forward. So what's happening around the world? Well, MSK, the spiritual home of the basket trial, have been using their impact panel, which is a high-based panel to detect coding sequence mutations, copy number alterations, and some selected non-coding mutations and structural rearrangements. And they've shown that almost 11% of advanced cancer patients can be triaged to a basket trial. The UC San Diego Moores Center are using the Foundation 1 companion diagnostic, and they were reporting a reasonably high number of breast cancer patients being retargeted to new therapies. But I'm sort of waiting on some more reliable information for that. And at Dana-Farber, and they're using the Onco panel, which is another in-house panel which they've had good success with. In the UK, the PBCP is the Personalised Breast Cancer Program, and this is based out of Cambridge, where they're doing a whole transcriptome and whole genome sequencing on every breast cancer patient. I recently contacted some of the leads of this study to get an idea of how their reporting is going. And it seems to me that they have no specific guidelines that they're willing to share on reporting at the moment. Suffice to say that they're trying to be flexible. They're very strongly advocating genetic counselling where possible, and they're doing orthogonal validation. And I found some interim reporting of the first 600 patients where they determined that 15% would have been better suited to a different drug and 60% would be eligible for clinical trials. So what are we doing in Australia, in particular Queensland? So a little while ago, we received funding from Queensland Genomics, which was originally called the Queensland Genomic Health Alliance, to fund this QImprove study, which is the implementation of precision oncology in breast cancer. And this is considered to be a clinical innovation project, wherein we're not using a NATA accredited test to implement directly into the clinic, but we're working very closely alongside clinical pipelines so that we can develop the infrastructure necessary to translate this to an implementation as quickly as possible. So the team draws really across Brisbane. So from our site at UMCCR and the Royal Brisbane and Women's Hospital, we have a number of researchers. We've also engaged some researchers from south of the river, which is a big deal in Brisbane, apparently. And we're moving forward with this, but let me tell you what our goals are first. So the idea is to really establish a framework for routine clinical genomics for breast cancer in the first instance, but then also to be able to roll this out to other cancer types. And we really want to determine whether the whole genome sequencing can inform second-line decision-making. And in this first iteration of the project, we're really asking the question of in how many patients would we have targeted them to a trial? In how many would we have made a therapy change, or could we have informed their therapy with pharmacogenomics? And also whether the whole genome sequencing is good value, or would we be better to move to an exome or a panel? And my feeling is that at this stage, we need to be so flexible with the amount of research that's coming out for new variations that we can pivot to, that whole genome sequencing with a virtual panel is probably the best way to move forward. So that's what we're trialing first. And this is how the program's going to work. Based in the neoadjuvant setting. So at the point of diagnosis, a decision is made for a patient to undergo neoadjuvant chemotherapy, and perhaps there are other hormone therapy or Herceptin therapy in due course. The neoadjuvant therapy means that, that the patient will start receiving chemotherapy before they have their surgery. So at the time of insertion of a surgical staging marker clip, we will take 3 extra core biopsies, which will go on to be whole genome sequenced, and we will also take blood for germline sequencing. The patient will then start the neoadjuvant chemotherapy, and we generally see around 6 rounds of chemotherapy according to a standard protocol, during which time the DNA extracted from the cores will be sent for whole genome sequencing and analysed through the services of Genomica in Brisbane, who are very skilled at applying signature analysis to the data analysis. So we will be able to return back data to a molecular tumour board meeting within 4 to 6 weeks. Then potentially the patient at the end of their chemotherapy may have breast imaging and then go on to have surgery. And it's at this kind of point that we will be able to determine whether the whole genome sequencing would have informed changes in second-line therapy or in clinical trials. So we then made a proposal to the Medical Research Futures Fund to expand this concept across Australia, and much to our surprise and joy, we actually received this funding. So we are now going to extend QImprove nationally and integrate our research program alongside so that we can capitalise on the recruitment of these really interesting patients and leverage the whole genome sequencing. So the program is supported by breast cancer trials, and we'll use the expertise of the QImprove group from Brisbane while also adding significant expertise elsewhere. So we have Stephen Rose from CSIRO will be bringing medical imaging expertise and also some very futuristic ideas around wearable monitoring devices. Nick Waddell from QIMR Berghofer and Genomica will be offering genomics expertise. We'll be working with Garani from the PA hospital to integrate an imaging pipeline, and also critically underpinning the whole program is Louisa Gordon's health economics work. We will also be recruiting through the services of Elgene Lim in Sydney, through Jeff and Shireen in Melbourne, and also working with Steve Fox on a circulating tumour cell pipeline, and also working with Christabel and Ben-Hur in Perth. And finally, we, with Stephen Rose as well, I forgot to mention that we will be working with circulating tumour DNA and a methylation proposal, which is a very similar concept to that which was clinically implemented for colorectal cancer with the Colvera test. So the research program, the first aim is to recruit 150 neoadjuvant chemotherapy directed patients nationally. And we're going to sequence the tumour in normal as we have planned to do for our QImprove study. Critically, we are also in this study funded to sequence residual tumour for a subset of these tumours as well. So we can make some really interesting observations about therapy-induced genomic changes. Aim 2, as I mentioned, is an MRI study, and it's really surrounding pre and post treatment MRI and an emerging field of radiomics, wherein genomics is integrated into the prediction algorithms of the MRI as well. And that is, just to be clear, not my area of expertise, but I'm working to understand it. And aim 3, we are going to be taking these pre and post-treatment bloods to inform liquid biopsy work. And this is to do with circulating tumour cells, as well as the circulating tumour DNA, as I mentioned, with a view to wearables to monitor recurrence. And as I mentioned, aim 4 is this comprehensive cost-benefit analysis. And it's through this particular analysis that we hope to understand the value of the whole genome sequencing and whether or not we would be better to move towards a panel. Although the continual need to update a breast cancer panel, as we assume will be the case, may prove to be challenging in a NATA setting. So that's something that we really need to investigate comprehensively to make sure. Thank you. If there are any questions, I've absolutely zoomed through that. So if you have any questions, please let me know.
That was a wonderful talk. Thank you, Amy, and congratulations on getting that recent MRFF funding. That's really amazing news for the program. Okay, so the first question, Kylie Goringer says, thanks, Amy. Is the sequencing done on FFPE material? And do you see any issues with that?
The sequencing is actually going to be done on fresh core biopsies. So we're going to get them sequenced, get them snap frozen and then sequence them from there. So we're trying to eliminate the FFPE factor for the core biopsies. The residual tumour will be FFPE, and we will do some macrodissection to enrich for tumour. And as ever, there will be a cloud overhanging the FFPE side of things, but we will be working with Nick and others at QIMR to try and work out how we can best account for that in the analysis pipelines.
Let's follow up and ask, does the FFPE sample screw up the mutational signature analysis, or is it still salvageable?
I think some are salvageable, but some of these newer signatures, I'm sure we don't know the answer to that yet. They won't have been looked at.
So while we're waiting for more questions, I'm going to ask one, which is, so you mentioned at the start, right at the start, the gene expression signatures, and said that perhaps the clinical utility of those wasn't clear. And I guess I'm just wondering whether you see the genomic signatures as kind of being better linked to being able to stratify into different treatment categories than the gene expression.
The prognostic outcomes of the gene expression signatures are clearly validated and very useful in terms of prognosis. But I think that in terms of prediction of targeted therapies, that the genomic measurement of signatures is going to be more productive and going to give a clearer outcome.
And just to follow up, some of the signatures you showed, there was no clear cause of the signature, I guess.
Yeah.
And are they generally less useful, or is it not really relevant whether or not you know what's causing that signature as to how useful it might be?
At the moment, it's impossible for us to know their utility because we can't then link the etiology to some sort of therapeutic outcome or benefit. So at the moment, they're not useful, but I expect there'll be a lot of work to disentangle their meaning. But equally, one of the big impactors on signature is age, and there's a lot of research surrounding that at the moment too. So patient age rather than sample age.
Yes. Okay, so there's another question from Michael Lee, who asks, what benefit has the UK program seen out of whole genome sequencing of breast cancer samples so far?
So just their interim reporting of 600 cases showed that apparently 60% would be triaged to clinical trials. And I think that it was 11% showed that they could be suited to a different drug. But in my recent conversations with the leads of that study, I think they still have a little bit of recruiting to go, but hopefully we can see a manuscript from them with some clear outcomes soon.
And Davika Ganasmurthy asks, great talk. Can you use mutational signatures to stratify treatment options, or will you be using transcriptional or other information?
We will use the mutation signatures in terms of inferring a homologous recombination defect to consider that they may be relevant for PARP inhibition or for platinum-based chemotherapies.
Okay, and Richard Tohill asks, says also great talk, and are you looking at any immune competent in the tumours?
That is always bubbling away in the background. We don't have funding for that at the moment, but it's certainly something we would be open to moving forward with.
And to Nguyen Dumont, also says great talk, and can you tell us more about the methylation work you have in mind for this program?
Look, I wish I could tell you more, but at this stage, the idea is to collect circulating tumour DNA from the patients, do methylation profiling on that circulating tumour DNA, and then to try and ascertain if we can move that forward in a similar way to which CSIRO did for their Colivera test for colorectal cancer. So in terms of methylation profiling for breast cancer, there's a huge body of work in a lot of different primary breast cancer types, a lot of which has come out of work from some of our Sydney-based colleagues, and we will be using some of that as a background to again perform almost a virtual panel to do some pre-screening on what we think might be a useful methylation target to then be able to chase in the circulating samples.
So in the methylation, so it will be bisulfites treated sequencing, I suppose, and then it's still with a panel, so you'll just amplify. Is that right?
Actually, I'm not sure whether they plan to do that with a panel based or not. I was just sort of implying that we would try to have a panel in mind of things that we, from the literature, understand to be a relevant target to begin with as a starting point.
Yeah. So Kylie Gorringe has another question. She says, I might have missed it in the study flow, but do you have to biopsy before you know whether NACT is offered, which means lots of extra people to consent, or do you go back for a second biopsy?
So the protocol would be to a biopsy for diagnosis, and then ER, PR, HER2 and standard grading and other clinicopath features would inform whether or not that patient would be directed for neoadjuvant chemotherapy. So it's actually a second set of biopsies, but only after they've been confirmed for neoadjuvant therapy. So we're only consenting those who are neoadjuvant. And then we will take those second lot of biopsies at the time that we put the surgical clip in, so that we disturb the standard of care clinical pathway as little as possible. So
Li Huan Guan says, what do you collect blood for if you use tumour for genome analysis?
So we're collecting the blood because we're going to be sequencing the germline DNA from blood as well, so that we can focus on the somatic changes. And we're also going to be using the blood for the circulating tumour DNA analysis and also circulating tumour cell analysis. So we're essentially, in addition to trying this as a clinical pipeline, we're going to then integrate the research program and leverage as much innovative research as we can from the pipeline.
I want to ask as well, you mentioned at the start that genome sequencing might be useful for identifying neoantigens. Yeah. I'm just wondering how you make that link between the mutation and then knowing that would be useful as a neoantigen.
I'm not sure that we can make the link that they would be useful as a neoantigen, but I think that there's just a common, there's a reasonably large body of work that suggests that the increased tumour mutation burden is predictive of increased neoantigens, just the nature of increased mutations. You're more likely to have some of them expressed. The link to those being informative is fairly tenuous from what I understand. But I may well have missed any recent papers, that's for sure.
So Kylie Granger asks, or makes a comment, sequencing blood DNA also helps identify if they carry germline BRCA mutation for streamlining to genetic counselling.
That's right. And that was one of our goals as well.
Li Huan Guan asks, if this technology is widely used in the future, how much do you think the patient should pay for the analysis?
Personally, I don't think the patient should pay for the analysis. I think that should be absorbed by the health service if it's going to provide the opportunity for us to really implement the goals of precision oncology, which is really to target a patient to the most relevant drug so that we can minimise side effects, which in turn minimises hospital stays and extra medicines and relieves a lot of additional pressure from the health service. So there's scope for really accurate targeting of medicine to relieve pressure. So we should be able to cover those costs. But that's my personal view, not supported by anyone else.
Treatments themselves can be extremely expensive, right? So not using expensive treatment, which is going to be useless, will save a lot of money as well.
Exactly.
And Davika Gamsmovy asks, how many samples do you plan to sequence?
For the QImprove local study, we're sequencing 40 patients. For the MRFF rollout, we're going to recruit another 150.
What's the time frame for that project?
The time frame for the whole project is 3 years. Yeah. But realistically, we could recruit 150 neoadjuvant patients across Brisbane very quickly, as in, let's say, 8 to 10 months. So there's, it should be an achievable and feasible goal.
Well, thanks very much, Amy. That was a very interesting talk, and I think everyone really engaged well with it. So thanks for that.